You know, if you live in parts of our region, you're significantly more likely than the national average to have cancer during your lifetime. You're probably going to be diagnosed later. That means that your outcomes will probably be worse, and sadly the statistics show that if you live in our region, you're more likely to die of cancer.
Improving cancer outcomes and reducing health inequalities. And I'll introduce our esteemed panel in a moment. Just wanted to do a bit of scene setting. And, you know, why should we care about inequalities in cancer in particular, which is what this session has said? Well, first of all, as we know, it is a massive priority for NHS and ICS systems. So we know it's built early cancer diagnosis into the Core 20 plus 5 framework. But we also know disparities in access, which disproportionately impact socioeconomically disadvantaged populations. So the point that was made earlier on about poverty and the role of poverty in all of this, as opposed to, you know, is health inequalities per se and inequality. So those are the reasons it matters. Just looking at about some of the those socioeconomic gradients of cancer, 42% Black women increase in mortality rate of breast cancer when compared to white women. 1 in 4 Black men will be diagnosed with prostate cancer compared to 1 in 8 white men. And with all of this, and the clinicians in the room will know that, you know, the stage at which their stage happens much later. And I'm going to talk in a minute about a use case which Professor Wardley led. And that really was started with a hunch from the medical director at the time of Greater Manchester. And we were doing work on hepatitis C using data insights for hepatitis C across the region. And he just said to me, you know, he said, I've got a hunch, and it's a hunch, and I can't prove it at the moment. He said, but the women in Bolton and Bury and Blackburn are not accessing Christie Care, and I don't understand why. And he kind of said, like, almost like that their consultants are hanging on to them. He said, can you prove the hunch? So we got together with Professor Wardley at the Christie, with Novartis and obviously ourselves, and we proved his theory. And one of the very simple things we did with what looks like an explosive firework, a Catherine wheel, in the top right-hand corner, is we used Google Maps. And I think it was Rowan that talked earlier about people having to take 6 buses to get to a research centre. It ain't going to happen. As the crow flies, it would take you, 20 minutes to get from Bolton to, if you're a fast crow, to the Christie. But the reality of it isn't that. And in fact, actually, a lot of it was about the journeys that those women would have to take that meant that their consultants knew that they wouldn't go to the Christie. We found all sorts of, and I'm going to invite Andrew to comment on this when we go into panel, we found all sorts of inequities there. So they were getting staged later, they were getting access to nice health technology assessments much, much later. And my understanding is at the end, they took Christie Care out to those communities. But I'll allow Andrew to do that study justice. So just a bit of scene setting there. And what I'd like to do now is go into the panel session. So what we're going to do, lots of questions from the floor, and thank you for being such a participative audience. Keep that going until 5 o'clock. And there will be no such thing as a stupid question, only a stupid answer. I'll give you one little anecdote on the example of a stupid question. When my middle daughter was 7 and used to be able to get up into the cockpit of a plane, my husband won a prize for her to go up because he worked out how much petrol or whatever they use in aeroplanes it would take to fly from Portugal to England. And she went up and she was 7 and her big sister was asking all the clever questions. And then she stood there and of course she got no front teeth or anything. And the captain had said to the kids, you can ask me any question you want, any question you like. And my 7-year-old daughter said, because she really admired this captain, what's my dog's name? Anyway.
So I'm Alistair Richards. I'm the Chief Executive of Northwest Cancer Research. And many of you are probably sitting there thinking, what's Northwest Cancer Research? So we're an independent charity. We've been funding research around cancer. There we go. It's a fairly obvious answer. Since I think 1948. But our mission at the moment is to kind of highlight and start to address the cancer inequalities that we see around the region. You know, if you live in parts of our region, you're significantly more likely than the national average to have cancer during your lifetime. You're probably going to be diagnosed later. That means that your outcomes will probably be worse. And sadly, the statistics show that if you live in our region, you're more likely to die of cancer. So actually, as an organisation, we've taken a research funder that's been funding basic research since, for 70 plus years, and we're focusing it in a new direction to highlight the challenges that we see around us.
Thank you, Alistair. Hey.
Yes, so my name is Marie-Andrée, and you'll refer to me as MA to make it easier. So I'm the country president of Novartis for the UK and Ireland, so I'm delighted to be here. And I'm delighted that in the last session, it started with Professor Rowan introducing the life science, pharmaceutical sector as a member of the healthcare system and how we come in for the same objectives. And it continued in the previous discussion around research, etc. So as Novartis, we're a focused company, but I'm here really to discuss from an impact standpoint and from a health inequality standpoint, specifically for cancer, where do we play in? And I wanted to just highlight one point that's important to me is in 2021, we signed a health inequality pledge. We were the first company to do so. And in a sense, it changed a little bit, like you referred to the ICS, in terms of a big change for the NHS, and a really important one. This change was really important for us because it meant that we focus on 4 key elements. The first one is understanding the access issues, and we have them in cancer. I love that the project was mentioned. We were part of that partnership, again, being part of the healthcare system and really being able to make an impact. The second is how this project actually got us to deliver a new model of innovation and allowed actually to increase the number of face-to-face appointments, virtual appointments, to see these patients with breast cancer and actually improve the outcome. So the first point of the pledge is really around understanding the access issue. The second point, and I'm looking here, it's a bit the Desmond Tutu quote that you had at the beginning of the day, right? So how do we use the capabilities that we have to help the system understand the data and identify? The second one are, what are new innovative ways to support the patients in the healthcare system, just like this project allowed us to really enable more appointments. The third aspect is what has been discussed a lot today already, is around research. But research in terms of having research in the country, and in this case, importantly, making sure that health inequality starts at the beginning of research. It's around access to innovation. I think Professor Rowan also mentioned it around how do we get deliveries, not just in the big centers, but outside. And then finally, the last part of the pledge is how do we impact the community? And here, that was mentioned by one of the questions from the audience. And for us, here is everything we do in terms of healthcare system, but also everything we do with the community. So we are in White City and in Grimsby. Grimsby is unfortunately in the last 1% in terms of health inequalities. But we found we work more on schools, we work more on youth clubs. So how do we make sure that we also address it from the beginning? So I'm looking forward to the discussion.
Thank you, MA. Ben.
Thanks. Yes, so I'm Ben Bridgewater. I'm the Chief Executive of Health Innovation Manchester. So Health Innovation Manchester is what we call our integrated academic health science and innovation system. So what we do is we work across the city region, and our partners are the 4 universities in Greater Manchester. They are all the hospitals, all the primary care services, the 10 local authorities, and that includes their economic development function in the life sciences space as well as their public health functions. And importantly, we also work very mindfully with industry. It's interesting, and we might get into this through the discussion, but the culture within the NHS and the culture within economic development and the culture within universities and the culture within industry are very, very different. One of the big challenges for my job is to be fluent enough in all of those things to actually be able to translate across that landscape. So we've got a bunch of things going on in this space, but what I would say, I think at this point in time, is that I was a cardiac surgeon for 25 years, and as I moved around the country, I would see patients who got a great deal from their local cardiac surgery services, and I would see patients who didn't get a great deal from their local cardiac surgery services. And the world is not equal, and we as a professional system with our regulators and stuff didn't do enough about that, and there's been an awful lot of stuff in the press around that. I spent 10 years trying to address that problem by collecting and publishing outcomes data. We made some progress. Did we address inequalities? No, but we drove the pack. So the risk-adjusted mortality after the 10 years that we ran this program was half of what it was, which meant we were saving a lot of lives every year. But the scatter at the end was the same as the scatter at the beginning. So we didn't address inequalities, but we drove the pack. Is that good enough? I don't know. I don't think it is personally. Mm-hmm. But what we've seen through the COVID pandemic is that inequalities and addressing inequalities is now at the top of the agenda, not something down at the bottom of the agenda. What's quite interesting, and you may have spoken about this already today, but if you look at the rollout of the vaccination, in many ways a fantastic success, going from having no vaccine to having a vaccine and getting it to overall to the pack, a pretty high level of penetration, really good. But actually some work which came out of some of the bits which I'm involved with demonstrate that we weren't equal about that, and we actually did not target the people who needed the most. The strategies that we had were not good enough. So I hope we're at a place now where addressing inequalities is at the top of the agenda. I hope we've gone past thinking about measuring inequalities, and actually we're actually having some specific things that we're doing to try and address those things. I think if we're honest about it, we probably know that we don't know enough about that yet. So we're going to have some humility in that things and try some good ideas and be really humble about measuring what we get, and hope that starts to change the dial. But I think we have a once in a lifetime opportunity right now to start to address inequalities in a systematic way.
Great. So what I'd like to do in this session is go to the questions that have been sent in ahead of the meeting today, both online and in person. So if you've asked a question in person, I will actually ask you to come up and ask it, and then I'll represent those that have come in online. So first question today, actually, it's one from you, Marie-Andrée. And I want to direct this question to Alistair and to Ben. And the question is, how do we ensure that health inequalities are being addressed at the start of the patient journey? So, Alistair, is that something that you'd like to pick up with?
Yeah, I can kick off on that one. This is absolutely critical, and I think Rowan Pritchard-Jones earlier referred to 90% of a patient's journey through ill health being before they see a doctor. So for me, the more information that we can give patients, and actually, perhaps I shouldn't say patients, but the more information that we can give the population at a very early stage, the better. Because the more information that they, the more awareness that they have around cancer signs, cancer symptoms, those are the things that are going to help them to access care services early, and report, get along to their GP at an early stage. That early diagnosis is absolutely critical if we want to sort of start to improve cancer outcomes for people.
Okay, Ben, second part of the question to you, if I may.
So, This is hard, isn't it? Because if you really want to address inequalities, you want to give people better housing, better education, better jobs. You want to have less pollution. You want to have different things going on with respect to access to cigarettes and alcohol, all these things. And there are some things which are big policy things which are way above my kind of understanding and pay grade. And I put those things in the important but too hard for me type box. So what I try and do is think about the things which are within my gift to do some things different about, and that's about how can we implement innovation which actually avoids what I would call the innovation paradox, which is why by introducing innovation you actually make the gaps bigger rather than make them smaller. So we believe that you should be doing innovation in the same way that you make software. agile innovation, where actually everything you do, you think in a really structured way, and you use the business diamond. And apologies for using a whole bunch of digital language, but that's now the way I see the world, and I think it's a useful way to see the world. So we talk about people, process, culture, tools, and tech. Okay. And actually, so when we're starting to think about addressing some of the problems that we've got, we think systematically in that way. Have we got the right people? Have we got people with the right skills? Do we have the right processes? Is our culture right? Do we have the right tools, and do we have the right technology? All of those things in that way. So actually having patience in that business diamond is incredibly important. You need to have patience with the right sort of experience of living with these things, people who understand what the barriers are, exploring those barriers. You need to have the culture within the other people in that business diamond who actually sees this as an equal voice, not something which they're paying lip service to, and so on and so forth. So I think there's something about actually creating these kind of things in a different way, and actually then using segmentation and micro-segmentation of the populations you're trying to serve, because one size does not fit all when you're trying to address inequalities, and being really mindful and respectful of that I think is incredibly important.
And Ben, knowing just what a health data enabled system Manchester has become, and people in here may not know, but a landmark study conducted in Salford, the Salford lung study, must be almost 10 years ago now. Going back to that point about practically, how can we actually start to address that at the actual start of the patient pathway? So once they're actually in the system, they've got a diagnosis, and how does that become routine and embedded?
So if you forgive me, I will speak about data for a moment. So I was a cardiac surgeon. I ran all the programs to collect and publish outcomes data in cardiac surgery, and I left to join a big global digital business. I believe that when I was in the NHS, before I left, I knew more about data management, data analysis than 99% of everybody in the NHS, and I probably did. That's probably a reasonable boast. When I joined a big global digital business, 99% of people in that business knew more about data and digital than I did. And that's the difference. It's chalk and cheese and stuff. And we're still not in the place where we have enough of those capabilities, which goes back to my point, people, process, culture, tools, and tech. So I think that's the first thing to say. The second thing to say is when I came in to the role that I'm doing now, which I've done for 6 years, I was on a mission to try and make us a digitally enabled health economy. And that was absolutely key to what I wanted to do. And it took me a while to really start making a noise about that in terms of trying to get people to a different place in terms of their understanding about why that was important. And I had a 5-year plan, and I hatched my 5-year plan in the beginning of March 2020, right? We then delivered the vast majority of that 5-year plan in the next 6 weeks, okay? Because suddenly there was an imperative to actually do some stuff. And I'll give you some examples. We had a situation in Greater Manchester where if you were Ben Bridgewater and you lived in the city of Manchester and you were seen in the hospital in the city of Manchester, your shared care record, which included primary care data, hospital data, and social care data, could be viewed. But actually, if you happened to cross the border and you were seen in Salford, it couldn't be seen. So there was issues not just with the data plumbing, there was issues with the information governance and stuff that set all those things in place. So what we did, because you had to do it in the global pandemic, is we drove all those structures and we turned on all the data pipelines, we got all the permissions, we put all those things in place. So we now have that 2.8 million people on a single platform with a shared data model incorporating all that data. There's some stuff that we can absolutely use that for in terms of direct care. There's some stuff that we can use that with respect to research, but we can't use it yet for all the things that we want to use it for because of some of those permissions. And one of the things that could happen to really enable this landscape that we really want to get there is changes in some of the legislation approach to actually data utilisation.
Thanks, Ben. Brilliant. Can I bring in, is Chris Mailer in the room? Chris, are you here? No? Okay, well, I shall ask the question on Chris's behalf. I've caught him out, down the road shopping. So Chris Mailer, who works for Novartis and definitely with his boss in the room, will not be down the road shopping. Maybe he's joining online. What role does the panel see for industry partners in improving cancer outcomes? And Emma, I'd like to direct that to you first. I'd like to invite Andrew in, because I think you've got a lot of experience of this, Professor Wardley, to pick that up second. And then Ben, I'd like to bring you in third on that one. Thank you.
Fantastic.
Emma.
And I'm actually very keen to hear also the input from my esteemed colleagues. So I think from an industry standpoint, the role I see is, coming back to my question, is actually at the very beginning. is at the very beginning, and it's going back to understanding, mining the data. You spoke about data. How do we understand? So it's important for us when we bring new innovation to already have that health inequality in mind from the beginning, to already look at those disparities, understand where they are coming from. And the best way to do that, to understand the patient journey, is also to do that with the system and with the ICS, the ICBs, et cetera, to work on that data and understand. So I think it's that partnership at the very beginning to really understand that patient journey, the inequality, and what are the needs. So that when we bring in and we have different solutions, we can tailor them. And it's how we can be part of the system. As I said, for me, it's one element. Life science, pharmaceutical sector is one part of the sector that allows us to do that.
And Ben, you made an interesting point. You talked about the different cultures between the ICSs, between industry, between third sector, government. And you talked about being fluent to translate, having to be fluent to translate across those cultures with one mission at the end. Emma, from your point of view, could you give a message to people in this room today about, if you like, the culture of life sciences, and ask, if you like, with regard to some of the challenges that you might have when you first start to engage with an ICS that you've not engaged with before? What kind of barriers do you come up against for engagement?
So in terms of, just going back to the beginning of your question, in terms of the way we approach it, and from our perspective, we kind of have a triple win check. So is it a win for the patient? Is it a win for the system? And is it a win for the company? Yeah. And I think my biggest ask is actually that upfront barrier. And it's interesting because from an industry standpoint in the room, we're about the only one, right, from the pharmaceutical side. And that's why I'm excited to join these panels, to kind of break that barrier, to have a discussion and to see, is there anything that we can do with the same common goal to really take our strengths together and advance it further. I think there's difference in the way we have different cultures, and you'll be able then to provide some insight on that. But I think it's that upfront barrier to be able to say, what is our common objective? And to trust that we do have the triple win element in mind from our perspective. And I think this is when, there's amazing projects, if I look at Greater Manchester, that are taking place now. Take the Determine trial, which won a BioNow award last week, which is really a great project with support from the industry. And there are two partners that are really going to help us address some of the rare cancers and ensure that those patients, regardless of health inequalities, have access and are identified. And those are the types of projects that what we need is just the first part of understanding it is a different sector, it is a different culture, but understanding that common objective that we have.
Thank you, Emma. Ben?
So the things that, in my mind, inhibit innovation are bureaucracy, hierarchy, and fear. And the things which encourage innovation are evolutionary purpose, enjoyment, empowerment, self-management, and all of those kind of things. And those are the kind of things that we take really seriously in terms of the way we do stuff. And I mentioned before that when we try and build our solutions and deliver our innovations, we try and do it like you do, you make software. And to have a flat, multidisciplinary structure which has got the right kind of facilitation. So almost like a scrum master. We don't quite use these languages, but it's a useful way of looking at it. So you have a scrum master who's good at facilitating, getting stuff done, and then you have the right kind of people in the room. And you're very respectful that actually everybody's bringing different things to the party. People with lived experiences of the diseases you're trying to treat are incredibly important in that, but actually they're not any more important. People might not like the fact that I say that, but they're not more important than your industry colleagues. They're not more important than your academic colleagues who've got expertise in implementation science. They're not more important than your NHS kind of people who are leading the services, which will almost certainly need to change to deliver the value. They're not more important than your digital colleagues who will be generating the insights in terms of where to act and how to measure stuff. So what we try and do is actually drive those flat multidisciplinary teams which are empowered to take things forward. Do we always get that right? No, but we're trying to do that. And actually what we're also trying to do is actually have the hard conversations when that's not right. So I think what we found is that if the motives are different in different organisations, the first thing to do is to call it out and to surface it and be respected that you're doing it for the right reasons, not the wrong reasons. So I'm not sure I've quite answered the question, but hopefully there's some useful insights.
Good.
And if I can just build on what you're saying, so because you were asking what is the first challenge when we have interactions, and we have a team that's really dedicated to work with the ICSs. So that's one of the challenge. But then again, as we have partnerships, and that's the approach that we're undertaking, is really to go high on these partnerships. It is to fail together, no finger pointing of saying, okay, this didn't work, that didn't work, here's what we understand, and we move it forward. And it is a true, when we say joint collaboration, that has to be really the essence of saying that's the team that wants to achieve this objectives. It doesn't matter, ICS, industry, or whatever partner.
It's not easy. It's not easy. And you know, we've already had this conversation a little bit today. You don't assume that everything you take on is going to fly out the window and is going to be absolutely a great success. It will not do that, and there will things which go wrong. And it's about not laying fault, but it's about having the hard conversations. It's like a marriage, isn't it? You know, you've got to work hard to make these things work. And I think particularly when you're having partnerships between the private sector and the public sector, you've got to work hard on those things because the prize is super, super big.
Thank you. Andrew, might I just invite you?
This piece of work came out of some residual monies left from devolution and a joint working partnership between IQVIA, Novartis funded, to look at access to secondary breast cancer systemic therapies across Greater Manchester. So I picked this as a subject to look at because I knew there was inequalities, because you look at the distribution and the provision of service from the cancer centre to the different DGHs, it wasn't equal across the system. And from that, you might suspect there's going to be differences in access to care. We did a piece of work in 2016 when we were creating NIHR Manchester Foundation Trust Clinical Research Facility, and we saw a very similar inequality of access to experimental medicines, not just cancer, but across the board. There's good access from populations maybe immediately in the vicinity of those facilities, but also from the south sector of the Greater Manchester and Cheshire conurbation. There was very poor access to those facilities from northeast Manchester, northwest Manchester, and we know that those are the areas of highest social and social deprivation, but also high areas of racial inequality. You might think that those co-locate, and we know they co-locate. And we mapped the access to those facilities against social deprivation, and it was pretty much exactly the same. So in 2011, I led a Greater Manchester strategy for delivering systemic therapies, taking those therapies out to where patients live so that they didn't have to travel long distances with difficult transport networks whilst they were suffering from cancer and suffering from the toxicities of cancer treatment. Now, I'm very familiar with that because I myself had cancer in 2009. So this was trying to investigate those variations, and we did see huge variations, and unfortunately Bolton access was about 66%. And the problem is, if you look at the oncology provision within Greater Manchester, it's probably the best provided network for the number of oncologists per population. There's about 100 oncologists in the cancer centre in Greater Manchester, a 3.2 million population, including the part of the Cheshire population that is served. But that access isn't equally distributed across the network. You might ask why that might be. But this was part of an exercise trying to look at those inequalities of access. There's also greater inequality of access to clinical trials. You know, we're hugely successful in delivering clinical trials. I built a partnership with pharmaceutical companies from the early 2000s when I came to Greater Manchester, and it was hugely successful. I delivered trials in South Manchester, Withington Hospital as it became, for the breast unit there, biggest recruiters to Big 198, the letrozole trial. I opened trials in Wigan. But things seem to have stagnated. That access hasn't gone out to the level that it should do. And I think we need to start asking questions about, can the integrated care system change that model? And it comes down to, unfortunately, vested interests saying that they will not help their partners to advance to the level that they should do.
Andrew, thank you, and thanks for stepping in. Really appreciate it. So on that note, I'm actually going to do something that drives Chamber absolutely nuts, because I'm going to ski off piste. So I'm actually going to ask a poll question that wasn't written down here. In terms of working with, so the question is, people who are here from an ICS, have you thought before about working with life science companies, pharmaceutical companies? So if the answer is yes, raise your hand. If the answer is no, raise your hand. That may mean we don't have any people from ICSs, and so my off-piste is now completely backfiring in my face. However, I'll push again. Ben, go for it.
So the structure we have in Greater Manchester is that we have an integrated care board, which is appropriately configured according to the sort of NHS England guidance and everything. And the life science engagement is largely outsourced to Health Innovation Manchester to do that, because we actually have the bandwidth, the focus, and we've recruited the capabilities in to do that. And I think that's a good model. So did somebody use the word perfect storm earlier?
Yes,
yeah,
they did.
So it's pretty hard
Chris.
getting the day job done in the ICSs at the moment. So I think creating smart structures which actually have a focus on some of the really super important things and making sure that there's the connectivity between those different structures is probably the key to this, rather than expecting people who are trying to get the day job done do other things on top of that.
Okay. So what I'd like to do now is I'd like to take a question from one of our viewers who's put this in online. So this is from Blessy Benny. Blessy is a quality executive at the MRI. So her question is, what must be our priorities in improving cancer outcomes? And I'd like to put that question first to Alistair, if I may.
Okay. So I could talk about early diagnosis here, and we've picked up this point before around the importance of early diagnosis in driving good outcomes for patients. But actually, I'd just like to pick on the personalisation agenda as well. And personalisation is often talked about from that perspective of understanding someone's genetic makeup and ensuring that treatments are tailored to the individual to get the highest level of effectiveness that we can. But I'd also like to pick up some of my background as well, which is in social care, because in social care there's a very different model to how you support and derive good outcomes for patients, because the commissioner comes along and they introduce you to an individual and they say, can you support this individual? And you wrap a service around that person. You understand their family life and their social life and their needs, and you wrap a service around them. Anyone that's been to an NHS hospital for something like a day case will understand that you arrive there at 8 o'clock in the morning and you sit in a chair for a long period of time. And then at some point the consultant walks in and you have this 20-minute period with the consultant where you give all your medical history, they look at you, they tell you what they're going to do with you on that day, they explain the process to you. And then they go off and you sit back in the chair for the rest of the day, and at 4 o'clock they go, oh, we're ready for you now, and they call you through into surgery. It's a tremendously stressful experience, which gives you the feeling of sitting in a sausage factory. So actually, and there are huge challenges here in the system, aren't there? But actually what would be amazing for patients and to get huge advances in positive patient outcomes would be to wrap an NHS system around a patient, so that when you come in, the service is ready for you, and you feel like you're the centre of the service, not the hospital consultant.
Yeah, brilliant. Ben, do you want to take a second part of that? Our priorities in improving cancer outcomes.
Yeah, so shall we whip it up a bit, maybe?
Yeah, let's whip it up.
I'm really building on the previous comment, and I half agree with it, and I'll explain why. When I was running a digital transformation consulting practice, I learned a lot about different sort of frameworks for doing things, and there's something called the value discipline model, where it accepts that for organisations to be great, they need to differentiate themselves along one of three axes. They either need to be great at operational efficiency, doing things lowest possible cost, all about supply chain management, just-in-time supply chain management, consistent standard, lowest possible costs, yeah? Or it was about product leadership, the best new products, Apple, good example of that. Or it was about customer intimacy, where you actually really focus on that special customer experience, and you do one of those three things. It doesn't mean you ignore the others, but it means that you try to be really good at one of those things. And actually what we get in healthcare is this, we're told we need to be brilliant at all of those things. We need to be brilliant at the newest possible services. We need to be really efficient because we're spending public money on it. And actually we need to absolutely have the greatest possible personalised care. And I don't think we're served very well by that, quite frankly. So the example I give in this particular space to try and make the point is, my office is just by Manchester Royal. If I was to walk down the stairs out of my office and trip up and break my arm, I don't care whether they call me Ben or Benny or Benjamin or Mr. Bridgewater. I don't care. I want my arm fixed. Operation efficiency. I want McDonald's. I want a Big Mac in and out straight away. That's all I want. If I happen to get something which is really nasty, where there's new emerging therapies, I want a very kind of much product leadership type approach to that, where I want to have access to those things and understand the choices and all those kind of things. And actually, if I've got a terminal malignancy, I just want to have the most customer intimate care. But I think we would do all ourselves a benefit if we start to think in a slightly more structured way about what we want to do to get the best outcomes at the lowest costs off the back of those value discipline things. It doesn't really answer your question, but it builds a little bit on your point.
Okay, and I want to pick up on something, a word that Alistair used there, and he talked about genetic makeup. I mean, we're always bashing ourselves in the UK, aren't we, about, we're the worst in the world for this and got the worst outcomes in that. We are a global leader, as I'm sure most of you know, in genomics, and we were the first country in the world to sequence 100,000 genomes, and now we have our target of 500,000 genomes. We've got UK Biobank, Genomics England, and so forth, and we've got a lot of now genetic screening for rare diseases in young children. But what do you think? How do you think we can really power that up? How can we use the power of that? And then the second part of my question is, I have a hunch, and I'm sure I've heard it somewhere else before, is that genetic screening is also suffering from inequalities. So who would like to take that question? Who feels qualified to take that? And I'm sorry, coming to you. Is there any evidence in the second part of my point about inequalities in genetic screening? And I'd be very interested if people from the floor think that there may be inequalities in genetic screening.
A small starter for 10 on this one. There are a really good number of companies out there that will, take a DNA sample from you, and at the cost of, usually around £1,600 to £2,000, will come back to you with a genetic picture of you, your family, and what your cancer risks might be. I think there's a whole set of ethical debates there, isn't there, around whether having that information is good and whether some of the information that they give to you is actually meaningful. But the thing that I'm most aware of is that actually it relies upon people being probably the worried well, and probably having £2,000 that they can put into that kind of thing. So I think this kind of screening is absolutely great if it provides you with valuable information and it's accessible for everybody.
Okay. Ben, do you want to add anything to that? And
I just think that
I'll bring you in, Marie-Andrée.
I think the personalised medicine debate is really important to be very, very thoughtful and deep on, because there's a very easy answer to this, which is almost certainly completely unaffordable. And so there's something about saying where, and this goes back to my previous point, where is it incredibly important that you do this? And actually, how do you do this in the context of a service which actually gets the right outcomes at the right cost for the most people? And there's choices which you need to be made in this thing. And I think they're big ticket choices where there needs to be a proper public debate to get to those things, not having people in closed rooms making decisions about this stuff.
Marie-Andrée, I can remember way back to one of your groundbreaking drugs, Gleevec, back in the day, and what had to be done to make sure that that person was suitable for Gleevec. You've got a long reputation in genomics. Any thoughts, comments there?
Yeah, I think in the genomics side, and by no means am I an expert in between these two gentlemen on the topic, but the one thing I would say is let's look at what we do right, because I think it's about bringing it to practicality. And I'm going to come back, and then I want to come back on the previous question as well. I'm going to come back to the determined trial, because that's exactly precision medicine.
The which trial?
The determined trial that is now going to take place in Greater Manchester, which is exactly looking at precision medicine, identifying and then being able to treat within that trial. So I think it's important to bring it back to practicalities and really put it in place. And we have to get better at shouting when we do things right. And I think that's really a right initiative to bring it to practicality. The same aspect on the priorities in terms of outcome. And you said not about diagnosis, but diagnosis is also absolutely critical. Again, there is the Health Accelerator project here that will take place in Greater Manchester to really focus on that cancer diagnostic and how to bring it up front. So those are the elements of bringing it in practice and making sure we do it from an equality standpoint.
Thank you.
Do you want to talk about that accelerator thing?
Yes.
Yeah,
That would be
please.
great.
And then while Ben's talking about that, I'd like to take some questions from the floor.
We've been successful in getting some funding for an innovation accelerator, and this is under Levelling Up. So the Levelling Up white paper, which I thought was a really good document, describes what you need to build in terms of the capacities and places to actually deliver to Levelling Up. And it's about having these different levels of capacity and making sure they're better connected than they are previously. And then 3 places were given the opportunity to receive some funding to take that forward. There's £100 million to support that. And those places were West Midlands, Greater Manchester and Glasgow. And each of those had a focus on those. And the focus for the Greater Manchester one was initially health innovation and life sciences as one bucket, and advanced materials as the second bucket. But that's been slightly added to with the clean growth and digital, rightly in my view. So we are taking some stuff forward in health innovation and life sciences. And the thing here is not just to keep doing the research you've been doing and do it more of it, but actually have a slightly different approach where actually you're focusing that additional funding on delivering to the Levelling Up agenda. So better outcomes for local people, more jobs, greater economic productivity, greater foreign direct investment, all of those things. So what we've done is we've selected our sector, which we think is the most compelling for this, which is around advanced diagnostics, and then we build a series of industry partnerships around that, including with Novartis and others, and a mixture of digital businesses and life sciences business and so on and so forth. But I'll give you an idea of one of the things we're trying to do with that, apropos the conversation here. So the lung cancer screening program that exists in Greater Manchester invites people based on an age segmentation to come and have a CT scan in a car park near you to try and pick up early diagnosis of lung cancer. And it's been demonstrated to a level which has been approved by NHS England this is a good thing to do. And rather than the lung cancers being stage 3 or 4 and incurable, they're stage 1 and 2, and therefore you can be cured of those things. But the way it works, and forgive me if I haven't got these numbers quite right, but they're not completely wrong, so don't kind of get me in trouble on this, but this is not a bad effort at it, is if you write to 100 people, 50 people will respond, 40 people will come to the consultation in a car park near you, 20 people will have a CT scan and you pick up 3 cancers per 100, okay? And that's a good thing because there's cancers which are, are potentially treatable by and large. But systematically, the people who come are the people who least need to come.
Yeah.
So the big intervention that we're trying to play into this is to actually do things in a different way, using the similar kind of approaches to retail tech, to actually target those populations using segmentation and micro-segmentation based on the data, and then nuanced messages through the right channels into those populations to try and drive into that space. And of course, if we do that, we will deliver better population health. We'll generate fantastically interesting cohorts for use into new trials and so on and so forth. We'll make a difference to population health and play into that economic development imperative as well. So, and we've got 5 work cases like that, which I'm happy to speak to anybody about at any stage. So that was announced on Friday last week. So we're now in the hard yards of trying to make that work.
Congratulations. So, right, I want to whip it up again. In the last 10 minutes of the panel, can I take some questions from the floor? I've got one over here, and keep your question punchy. Come to the floor. Who are you? Where are you from?
G'day, I'm Professor Jason Lang from a company called ProMake. Essentially what we are is a diagnostics company that works on lab-on-a-chip systems. What we're developing, we're partners now with Microsoft to create a disposable lab-on-a-chip system to be able to detect biomarkers and all sorts of pathogens at home, but by pulling data in a real-time environment. The question is, as far as tech advancing so quickly right now, is it being adopted, and or is it willing to be adopted to be able to pull data so that you can do the calculated analytics that you need to help benefit in respects to equality, to getting test results, research and diagnostics all in one kind of involved envelope. So, and how would we go about, if that was the case, to get involved more with the ICS and bigger companies, because it needs a bigger footprint to take this further, to be able to pull enough data to create the gathered results. So that's my question. Thank you very much.
Who'd like to take it?
Yeah, I'm very happy to have a conversation with you about the specifics of it all. But in terms of the generality of it, the big challenge that we have with extracting significant value from innovations, particularly digital type innovations, is working through this kind of process. And again, this isn't quite right, but it's not completely wrong. Digitize, yep. Pivot your operating model, pivot your business model, okay? And actually, the best digitization, the best innovations don't work unless people do things differently. And that's what I mean by pivoting the operating model. And that's super hard. It's hard anyway. It's particularly hard when everybody's strung out trying to do the day job. And we heard from Andrew earlier about some of the morale issues, some of the targets that they've got. So it's that pivoting the operating model space is hard. And then we know this doesn't really work until you pivot the business model. And that's actually what creates the scale and sustainability. And actually most of this stuff works on business models which were set up by the NHS way back when. So what we try to do is to try and find great innovations, then try and drive that stuff through that kind of process. But I'd be very happy to have that conversation with you.
Thank you, Ben. Adam, please. Any other questions from the floor? Because I've got a couple online here. So any other questions from the floor? No? Right, well, I'll go to the online ones after Adam.
Hi, I was that guy earlier. Observation, and so the genomics, the Microsoft stuff, the innovation, the transformational stuff we talk about, it's great, it will create step change, but actually, just to the point I made in the presentation, we've got excellent screening programs and a complete inequity of service across demographics. So whilst those innovations will come and will create step change, 75% of familial diabetes is undiagnosed, but the screening test already exists. And we know that Afro-Caribbean women are more at risk, but that we're not engaging with that population because it's hard. So I think I'd just like the view of all of you really, that the future is bright, but actually there's things we can do today to use the tools that we have at our disposal. It's just about swimming upstream or looking for the broken bridge and finding the right language, the right narrative to engage with the populations that we know would benefit. And so how do we do that while, all the great stuff that's on the horizon arrives, because we can't. I just get a sense that sometimes we fold our arms and go, it's all going to be great in 10 years' time. Shared care record, it's going to be beautiful.
Adam, come on.
Sorry.
Succinct. Emma, she's got the question.
So I think it's a great question, Adam, in terms of where do we need to focus now. And I'd be very keen to hear from my colleagues. I think the core 20+5 did you present it? Yes. The implementation.
Yeah, but he didn't make it up,
exactly.
right?
No. You know that comes from Bola and the team.
Who couldn't
but
be here
I
today.
really think the core 20+5 is exactly that. And interesting, yesterday I was sitting with a startup that got me so much energy because they were designing, or they currently are designing, a software to see in that population specifically who's missing their appointments, why, and what would be the best way. What does work, from an AI standpoint? What are the elements that are coming up so I can make sure that if I call Adam, he's in my core 20+5, I know how to get him to the clinic. So I do think there's a lot of energy around the core 20+5, and we need to continue that and have the right tools around it so that it can be implemented. I know when we look at our primary care teams, that's a big focus because the idea is there, it is beautiful, but it's how do we implement it to address those clinics. For me, it's not reinventing the wheel. We have the tool, and it's how do we use it, and maybe figure out the execution tool to go further and to help the clinics to be able to use it.
Alistair?
I don't think I'd be the first person to say education. I think that one's been done a few times. I think the really good news here is that while research can sometimes be incredibly expensive, education is often remarkably cheap. So actually, if we can get out into local communities and speak to people in a really non-judgmental, accessible way, then we can drive much greater engagement with health services, whether that's in their current form or in a future 10 years bright sunlight innovated form. But actually what you first need to do is to get the people to engage. So that's where the education piece fits
Thank
in.
you. Ben?
I'm slight risk of getting myself in a bit of trouble with my answer to this, but
You always do that.
Faint heart, never won fair lady, as they say. So you talked about wheels, I think, didn't you? So the sort of penny farthing thing, where actually NIHR put £1.3 billion a year into research, but the amount of money that actually goes into the hard last mile of integration of research is diddly squat. And actually, whilst you can argue whose job that should be, the evidence suggests that it's hard, because if it wasn't hard, it would have been done and you wouldn't be asking the question. So I think there's something about accepting that bit is really important, and probably the most important thing in my view, making sure that's kind of resourced up properly and tooled up properly with respect to capabilities, and most importantly, method. Because I don't think we know how to do some of these things. Therefore, we need to get into this process of agile delivery of these things and find out what truly works and then scale up that very rapidly.
Brilliant, thank you. Okay, so if there aren't any more questions from the floor, I'm going to take one from online. So this is from Jason Woodwell. I'm really pleased to see this question in here. How can pharmacy be better integrated into the wider system? Pharmacy is perfectly placed to support with cost-effective medication to treat illness, and GPs perfect for diagnosing illnesses. Maybe pharmacogenomics as a service in pharmacy. Who'd like to take that?
I'd take it. I agree. We need to do it. I don't know how, but we do need to do it. But the point is very well made.
Well, you had a great example, didn't you, in the hepatitis C initiative that you did across Greater Manchester, where we were trying to reach drug users.
Yeah. So we've done a fair bit of this. And it's good coming to do these panels, isn't it? Because it fires you up about the thing you're going to pick up and do tomorrow. And this is the one I'm going to pick up and do tomorrow. Because what we're constantly trying to do at the moment, and you may argue this is right, you may argue this is wrong, but I would argue it's a necessity, is that when everybody's so busy doing the day job, doing innovation to get better outcomes for people is almost impossible. So you have to do things in a different kind of way, not just transform what you've already got. And I think picking this stuff up in a really compelling way is just going to be incredibly important, and it's something that we need to do. One of the things that we have tried to do, and again this has been quite challenging, is it needs to be underpinned by some of the data assets. So actually making sure things like the care record is actually available in the right place to be used for the right reasons as well. And that's around getting around some of the information governance challenges which still exist.
And again, we have to think about footfall. The footfall in a pharmacy, whether it's in Sainsbury's or in a privately owned pharmacy, is often much higher because people are just going in for things that they need. The blood pressure initiative that's going on, measuring blood pressure in pharmacies, is out there. The pharmacy contract needs to reflect it as well.
And we did a little pilot project of putting health check things in co-op stores. And what we found is that the people who went into co-op stores to have these health checks were the people who don't pitch up to their GP to ask those questions. So different channels, different kind of locations and stuff is something that we need to be thinking harder about. Some things that happened in COVID which actually took things forward quite a lot. Some things happened in COVID, from our perspective, actually stopped a lot of the things that we were trying to do which were quite good and we haven't quite picked up again, and this is one of them, I think.
Marie, did you want to make any comment on that?
I would agree that there's a role, and it's a question of finding the how. But it is around that partnership and that discussion at the beginning.
Okay.
Yeah, just to chip in on that one, the pharmacy network is absolutely brilliant. It is so accessible. It's so easy to get there. Particularly at the moment, we're seeing people really struggling to get GP appointments. And one of the things that we're seeing is that the pharmacy network is being used as a buffer by some of the GPs. So you ring up your GP and they say, have you been to a pharmacist? And if you say no, they say, okay, go and see a pharmacist first. And what that's done is it's shifted a workload into the pharmacy system, some of which they can deal with, some of which, that might be the most appropriate course for that individual. But it's also created a huge number of people walking through the doors for whom they can't provide an answer and who actually are just going to loop back to the GP. So I think that the future is amazingly bright for the pharmacy network. There's so much new technology that's coming through now, which will make tests available at that drop-in level. So, tests for things like prostate cancer that you can just walk in, take your sample and, have the pharmacist analyse there and then. But actually we have to be realistic about there's only so many trained pharmacists and only so many shop fronts that people can go in through. So we need the system not to unload its pressure into other environments.
No, 100%. And can I ask, just on ICB boards, what's the role of the local pharmaceutical committees? Are they also part of the integrated family? Anybody got any comments on that? Do they have a place?
Yes, they do have a place. How effectively it all works, I don't know. But there are certainly structures.
Yeah. I saw somebody. Okay, I'm going to wrap this session up now. So again, in the traditional way, I'd like to thank our panel. So thank you very much indeed.